Hi, and welcome to my channel. I'm April, and I am currently an FNP student at West Texas A&M University, and today I'm going to be presenting a slide deck on amyotrophic lateral sclerosis. Enjoy. A little bit about myself before we get started is I've been a nurse here in Texas since 2009. I went to Dallas Community College, El Centro, and I got my ADN. Then I worked at Hughley Hospital for many years in CVICU. While I was working there, I continued on with my education, got my BSN from UTA in Arlington, and then I eventually did leave bedside and pursued more of a business career in nursing, and I've launched several drugs with pharmaceutical companies with really a high concentration in cardiovascular drugs and neurology drugs. In my free time, I love just running or being in my garden, being outside really, and spending time with my sons. Alright, so three objectives for my presentation are essentially, healthcare provider education. We're going to review pathophysiology. We're going to talk a little bit about clinical manifestations, what you see in the patients when they come to your office, and what are some diagnostic tools and labs that we would consider for these patients. And then second objective would be resources for our patients and caregivers. That's really important, such as genetic testing, what treatments are available, of course, and then how do we educate them and what are we educating these patients on. And then lastly is some research updates. So what is ALS? So ALS is a devastating neuromuscular disease. It affects both the lower and upper motor neurons, and it progresses with muscle weakness, and essentially it ends in paralysis. This disease can present anywhere from 40 to 70 years old, but predominantly in the fourth decade of life. And it is mostly in males. However, females do get ALS. The majority of the diagnoses for ALS are a sporadic ALS, just meaning that there is no family history of ALS, and with 10 to 20% being a familiar form, meaning that there is a link genetically in family members, direct blood relatives. However, as testing and genetics and just technology improve, and running genetic tests on patients who are of sporadic cases, they are noticing that they carry some of the same mutated genes as they have seen in the familiar form. So that number will change as time progresses. Alright, so how are we educating our healthcare providers when teaching them what is ALS pathophysiology? So it's basically deficits in the axonal transport, some abnormal synthesis in the filament units, growth factors, glutamate exotoxicity, just high glutamate levels in the spinal cord, mitochondrial dysfunction and oxidative stress, of course, at the cellular level. This all leads to degeneration and death of the neuromuscular junctions, again, in both the upper and lower motor neurons. A significant decrease in the large motor neurons in the brainstem, spinal cord, cerebral cortex, and continuing degeneration in motor neurons. Interestingly enough, it is not involved in cranial nerves, in certain cranial nerves, so just know that the eyes and the heart muscles are not affected, but essentially every other muscle is. And so when these patients reach the point of paralysis, they'll still be able to move their eyes, and of course their heart beats without issue there. There is axonal degeneration and secondary demyelination in these patients, and that essentially just results in a motor neuron death, it's just altered neural functions of the microglia and astrocyte functions. And then our muscles, humans, really compensate by distal intermuscular sprouting. So that's typically what happens in these patients pathologically. So some ways that these patients will present in the clinic. And every patient is really different, and not all patients are going to present exactly alike. The disease presents at different areas of the body. It's asymmetrical, so we just, everyone is a little bit different in a certain sense. But they may come with weakness of a limb or both limbs, slurring of speech, difficulty swallowing, cramping of their muscles, twitching. ALS is primarily 60% manifest in spinal form with muscle weakness, focal muscle weakness. Typically it starts in the arms and then moves to the legs. Muscle atrophy and spasticity are progressive as well. Patients lose, unable to walk, loss of gait, dexterity, fumbling around, not able to hold a cup, lots of falls. Patients are what they call themselves clumsy because of this weakness and how it progresses. Typically, there is no sensory, mental, or autonomic systems that will present in the patient. However, there have been found now that there are varying levels of cognition that can range anywhere from a frontotemporal dementia to normal cognition, but I will say that the frontotemporal dementia is rare, and majority of patients that do present with ALS are completely fine cognitively. Eventually, of course, the disease will progress to paralysis, like I stated, in the upper and the lower motor neurons. Classic presentation for these patients are the hypotonia, so that's muscle issues such as spasticity, atrophy as well, so that's muscle wasting, and metabolic changes. So there's a lot of weight loss in these patients, and that could be because of weakness in their jaws, unable to swallow, unable to chew food, and then also the muscle wasting also tacks onto that weight loss. So you will see these patients as time progresses and they come back to you over and over again, essentially shrinking for a multitude of reasons. So what are some of the things that we can do for our patients as far as testing them in labs and diagnostics to test for ALS? So there's not one tried and true method for ALS, but there's a multitude, a combination of them per se. It really does depends on the healthcare provider doing a comprehensive medical history and physical neurological exams. They must verify the lower motor neuron degeneration and denervation, and that is done with a electromyography with a muscle biopsy, which can verify the lower motor neuron denervation and degeneration. As technology improves, it is now being shown that there is a non-invasive electrical physical protocol that includes scans for compound muscle action potentials, along with nerve excitability testing as a early marker for diagnosing ALS, which is wonderful for patients, but it's twofold. So we have to be careful with that, and doing that for patients that have not been diagnosed with ALS. Cerebral spine, such as family members that come to you for genetic testing and want those tests as well. But there are cerebral spinal fluid biomarkers that can also help with the diagnosis, looking for that high levels of glutamate, right, that we talked about before, as well as imaging, looking at the MRI images. We want to rule out other other diseases that might mimic ALS, such as MS. All right, so some other resources for patients and caregivers. There's going to be a lot of questions about genetic testing and risk factors. So what we know so far is that over 40 genes have been identified for ALS. some big ones are the SOD1, the FUS, and the C9ORF72. There are many ongoing clinical trials that are concentrating on these genetic mutations. Another big one is the TDP-F43. It's a major contributor to the toxic nature found in glia cells and motor neurons. We don't know if these genes are becoming mutated because of environmental issues, or is that something that has happened since birth? So those kind of questions are still being investigated. As of now, clinics, specialty centers, ALS centers, even pharmaceutical companies that are working with new drugs and modalities for ALS are asking blood relatives of patients and even patients themselves to consider these genetic tests to help move research along. But in healthcare providers' offices, you are able to take these genetic tests. However, like I stated earlier, it is twofold because it is quite sensitive to have a patient's blood relative come in, or even the patient themselves, and have these, confirmation genetic tests done. So you want to make sure that you have a trained professional on staff that can deliver these results, such as a genetic counselor. So what are some of the treatment options for patients? So there are several now medications on the market that can treat for ALS. As the years come and go, some of them have come to market and then they've been recalled by the FDA. As of now, Riluzole is, I'm going to say, tried and true. It's been on the market over a decade, and it is one of the medications that allows for life to be extended. However, it does not stop the symptoms. And then you have Tofersen, which really concentrates on the SOD1 mutated gene, and that is showing really promising results. We also have a new Dexta. It helps control emotional outbursts. With patients that have ALS, they do have a hard time controlling crying or laughter. So that is one of the other aspects of ALS, and New Dexta is new to the market, and it helps patients control those emotional outbursts. Rehab management, supportive services are so important for our patients that are dealing with ALS. The main goal is to maximize independence, maximize function as long as possible for these patients, because it's all about quality of life for them and the caregivers. As dysphonia develops, there are special devices, and they've been on the market since the early 2000s, where it's progressing, it's changing, it's getting better, but the latest device is pretty awesome. Patients are able to bank all their words, so they'll record themselves talking, and essentially when their voice does leave them, they are able to, with their eyes, write what they need to communicate onto a screen, and then that screen will just speak for them, but in their voice. So essentially that part of them is still with the family and caregivers. So that has been so impactful in regards to using technology for our patients that have ALS. Having oral suction with yankers accessible because of the excessive saliva. Essentially ventilation devices will be needed, because as their lung muscles weaken, they need that support. Hospital beds are needed, wheelchairs, electric wheelchairs essentially, and rails and ramps around their house are what we need to provide for our patients. And of course, psychological care is needed by both patient and caregiver. Some of the resources that we can offer our patients are just, teaching them what is ALS, what does it mean, what are the signs and symptoms, explaining the progressive nature and the prognosis, Reassuring them that there are treatments to make the disease course more comfortable as the different stages come and go. And that we're going to try to keep them as independent as long as possible, teaching them to cut up their food, micing it, blending it, adding baby cereal, adding thicket to their water to help swallow, because these patients have a really hard time swallowing thin liquids and they tend to choke a lot, especially on their own saliva. You want to make sure that you're educating the caregiver to take as many breaks as possible and don't neglect themselves. Let them know about ALS support groups, counseling, social services, and of course spiritual support for the family if they are open to that. And then prepare your patient and caregiver for the eventual death that will occur, as there is no cure currently in grieving process. But I don't want to leave you on a sad note. Research is always changing, and so there's no cure yet, and yet is the key word. So some of the things that I was able to pull up is, with our EMR systems and how we enter this data on all our patients, it's really important. There is a Capture ALS that healthcare providers can use, and that just allows us to, allows them to just gather a lot of data on patient population, true patient population, and how it's affecting our patients, and how that can really improve patient care. And then there are so many ongoing clinical trials right now where sporadic and familiar ALS patients are being studied in regards to AAV-mediated trophic support, the controversial CRISPR, RNA interferes, and so forth. So there's hope. We haven't found a cure yet, but we want to make sure that we're providing the best possible care for these patients. Here are my references. Thank you so much for spending this time with me. I really appreciate you, and I hope you enjoyed.